talked to Brian, he said, yeah, why don't you talk about some of the big articles in the last 12 months? And I was thinking, this is going to be fun, go through the really heavy-hitting critical care. And then I got the title, and of course, the big articles of the last year are not necessarily the practice-changing articles. You have lots of big articles that don't move the needle at all, and then smaller papers that really change what you do on a day-to-day basis. So of course, it's a very different kind of talk. But I hope that you'll enjoy it, and what I've selected, I think a couple of these may move the needle for you. The reason for that is that innovations come in different packages. Obviously, they can come in the New England Journal, they can come in smaller journals. And the whole study of innovations is fascinating. And I think Brian probably wouldn't ask me to speak again if all we talked about were typewriters. But typewriters are a good example of how innovations diffuse throughout society and over time. So this is a photo that I took over the weekend at one of the restaurants nearby. And what you can see in the typewriter is actually all of the keys are locked right in the middle. And original typewriters were based on, you would press a lever, the hammer would come up, strike the paper, and then by gravity it would fall back down. So does anybody know this history? Has anyone heard about typewriters? Show of hands. Okay, so Brian knows about it, a few people know about this. It's really interesting. So this was a problem. How do you prevent the keys from getting locked up next to each other and the hammers from striking each other? And so that was the basis of the first keyboard, which is the QWERTY keyboard. And this was an anti-innovation in a way. Right, I should say it was designed to make you move slower and less efficiently, which is not a typical innovation. And more of the keys were put on the left side that would be struck more frequently. Most people are right-handed. And the order of the keys was designed so that you wouldn't have concurrent hammers landing right next to each other. Okay, so it tried to slow you down to make the machine actually work. And the typewriter stayed that way for the beginning part of the 20th century until 1961 when IBM developed this. This is the ball, and this is the Electrolux. And what's cool about this, if you remember it, I know I've used this, there's no way to jam the keys here. So that really changed things for typewriter development, and you no longer needed to have this extra slow keyboard. So a second keyboard was developed, the Dvorak layout. Does anyone in the audience use the keyboard on the bottom, Dvorak? Okay. So this is very different. So the Dvorak has, on your home row, 70% of the letters that you use, at least in English, are on the home row. You'll see that most of the other letters are above. So this was really a major advance. This keyboard is much better. And you don't have the problem of the keys landing next to each other and jamming up the keyboard. So we have these two innovations. We have the Electrolux in 1961, which spread quickly throughout typewriters and became the standard almost overnight through the 1980s. And then we have this other keyboard, which is vastly superior, but of course, none of us here in most of the world are using it. And that's really what innovations come down to, is that you can have a great idea, and there's this belief that based on the strength of the idea, it will propel itself through society, that if something is just better, less expensive, any of the parameters that we think of when we talk about innovations, that it will propel itself. And that's clearly not the case. And a lot of that has to do with us, and has to do with where we fall on this kind of innovation curve. And all the way on the left are the innovators. These are people that are actually creating new ideas. Then you have the early adopters. In some domains, probably some of us are in that space. But I think that, at least for critical care medicine, I rarely am an early adopter. I like to think of myself as on the cusp between the early adopter and the early majority. And clearly for typewriters, the ball was immediately adopted and became widespread while the keyboard did not. So I did a search yesterday from PubMed and looked at the last 12 months. Looked at mesh terms for critical care to see what are we going to talk about. I wanted to see if anything new came out. So this is the number of articles that have come out in the last 12 months. So certainly in here there are some new keyboards, there are some new ways of configuring the typewriter, so to speak. But we're not going to cover 10,000 articles. We're going to look at 8 articles today. So the first one, this is interesting. So show of hands, this is a paper that came out in Lancet in the spring on using prednisone therapy for community-acquired pneumonia. Is anyone, raise your hand if you're familiar with this article. Okay, good. So a couple of hands have gone up. I thought this was interesting. These were patients that were presenting with pneumonia, a range of severities. 50% of the patients met the criteria for severe pneumonia, randomized to 3 days of prednisone versus placebo. There were about 400 patients in each arm. Good case mix, good case severity. Their primary outcome was treatment failure. And so you can see the curve here, and what they're looking at is just this is the probability of instability, and looking at how quickly patients normalize their vital signs, how quickly they look good again. So the group with prednisone therapy had a significantly decreased time to clinical stability, and they also had a decreased length of stay. Now, there was no mortality difference. Interestingly, no readmission difference, but that would also be important. And there was no complication difference. A little bit more hyperglycemia in the prednisone therapy group. But this is at least interesting, because there have been a lot in this space. This thought that when you have a pneumonia, whether it's a moderate pneumonia to severe pneumonia, that the cytokine cascade is working your lungs, working the rest of your body, and if we were able to provide some kind of immunomodulation of that effect, that we could perhaps achieve clinical stability more quickly. And that was their theory, that this would decrease lung and systemic inflammation. And they did a nice job. They measured other markers. They measured a whole panel of cytokines. They found that there was really no systemic immune suppression, and that there really were measurable drops in the things that we'd expect. That there was a measurable drop in CRP, there's a measurable drop in interleukin-6. So they not only did the bench side, but they did the clinical component, and a well-conducted study. Interesting editorial, if this paper really speaks to you, by Julian Anand, calling for a major change in practice. I thought this was interesting. This got me thinking. So back in the spring, and there was another article that came out right around the same time. This one in JAMA just a couple weeks earlier, looking at a slightly different subset of the same patient population. So now we have patients not just with pneumonia, but have severe pneumonia. So these were only patients at the highest illness severity score, and also they looked at biomarkers. They did patients that had high CRP. So these are the people that you really would expect to benefit from this therapy. Here they used 5 days of methylprednisolone versus placebo, much smaller trial. The last trial, 400 patients in each arm. This was just over 60. And here we're looking at time to treatment failure. And again, they found a difference between the two groups, between the methylprednisolone and placebo. And treatment failure was defined as a lead to change in antibiotic, change in clinical status. They had a composite outcome, but all things that resonate with me, things that matter. And the treatment failure was much lower. You can see it was 13% versus about a third in the standard therapy arm. And they also had lower inflammatory response when they measured the various biomarkers and cytokines. No change in mortality, no change in length of stay. Then over the summer, both of these trials were wrapped up in a systematic review in Annals. And so there were 12 trials collectively that were pooled with about 2,000 patients. I'm just going to walk you through a few of the forest plots. I was joking and crying if the power went off. These would be hard to do with my hands. But what they've done is they've stratified. The first one, what you're seeing is the effect on mortality for a therapy for steroids versus placebo. In the top group, this is the severe pneumonia. And we can see that the Torres trial that I just talked about is right down here at the bottom. And you'll remember I said that there was no change in mortality, there was no change in length of stay in that trial. But when pooled for the severe group, the collective, you can see that large diamond at the bottom, indicates that they're signaling that for severe pneumonias, steroids could have an impact on mortality. Perhaps less so for less severe pneumonia. And the Blum article, which was the first article I talked about, right here at the top, and you can see that it crosses the midline. And that again, the diamond for all of these trials together, that there's no benefit in the less severe group. Nevertheless, they pooled all of these, even though that doesn't make complete sense to me, because we've shown that there's, for different patient populations, a different effect. But they found that there was a benefit. And so they also looked at mechanical ventilation, and here you can see pooling the trials that included patients that had mechanical ventilation as a benefit, and also in the setting of ARDS there's a benefit. So collectively, what are the conclusions that we can draw from the use of steroids in pneumonia? When pooling all of the 12 trials, we're looking at a reduction in mortality of about 3%, reduction in need for mechanical ventilation of 5%, and a reduction in hospital length of stay. So I think this is interesting. The editorials have been on both sides of this, both that the time is now and the prime time has not arrived, but it certainly has gotten me thinking. When I talked to Brian about this, many of the patients that we're admitting with pneumonia anyway have other reasons that you would start them on steroids, whether it be COPD or other conditions. So some of this may have been a signal that we were already recognizing in another patient population. Dr. Kumar.
Just curious, low-dose steroids or high-dose steroids, or did they?
So it is low-dose steroids. So the first review is 1 milligram per kilogram, no taper, 7 days. The methylpred was, I believe, 0.5 per kilo over 5 days. So it's not thought to be, but certainly not high doses of a medrol pack. Good question. So, is this ready for prime time? I don't think so, but I think that it's definitely very interesting, and we already know that there are a subset of patients that benefit from steroids. So I think that you're going to see a little bit more of this in the future. This is a very interesting paper. So I know Amy Kirschenborn very well. And this is a project she's been working on for the last couple of years. Just again, a show of hands, anyone who saw this, that this came across your radar screen, association between arterial catheter use and hospital mortality in intensive care units. Okay, so a couple of hands here. This is really good. So she used a database that's called the Project Impact database. It's a huge database of ICUs in the United States. Lots of papers have come out of it. She looked at 60,000 mechanically ventilated patients. That was just for the primary analysis. You're going to see there's some sub-analyses where much larger cohort. The primary exposure was arterial catheter use, primary outcome, mortality. And I am telling you, she was looking for a signal. I mean, she really thought that this was going to have an impact. So she came into it with a variety of modeling strategies using both propensity matching, logistic regression, combinations, every which way that you could slice the salami, she was looking for a signal, and did 9 sub-analysis. Is there a benefit of using arterial catheter in the management of your critically ill patient? So here are the subsets. As best as they could not find any benefit in the subset of patients that were mechanically ventilated medical patients, mechanically ventilated medical patients by a variety of illness severities, mechanically ventilated medical patients in a mixed ICU setting, mechanically ventilated surgical patients, all patients in septic shock. And the only group that they found there was a difference with arterial catheter use were patients on vasopressors, and it was higher. Now, what do you make of this? Do we think that arterial catheters are actually killing the patients that are on vasopressors? I don't. I think that there's some unmeasured severity of illness here. But it makes us think about a diagnostic maneuver that, unless it's linked to a specific therapy, is not going to result in a better outcome. We've already gone through that with pulmonary artery catheter. So I think that this is very interesting. In their conclusions, they don't overstate matters. They say that this is another example of a diagnostic test that perhaps should be investigated in a randomized controlled trial setting. I know that this has changed some of our practice, and that we're using fewer arterial catheters, and that the common notion of that your non-invasive is not going to work at the extremes of blood pressure. Well, you're going to treat the extremes of blood pressure. You're not going to let someone stay at low blood pressure or high blood pressure. So treat it, get the blood pressure into a range where non-invasive will work. So this got me thinking. I think it's, are we ready to give up on arterial line catheters? I don't think so, but perhaps we are using them and expecting more out of them than they can deliver. So this was an interesting article. This actually has changed practice dramatically at the University of Pittsburgh, and so this is the effect of retrievable IVC filters plus anticoagulation versus anticoagulation alone in patients with pulmonary embolism. Show of hands, familiarity with this paper. Okay. So this is interesting. So these were patients that had an acute pulmonary embolism and a DVT. Okay. And they were randomized to a retrievable IVC filter, and the primary outcome was recurrent PE, but they also looked at mortality and morbidity, and this just feels like it makes sense. You have a patient who has a PE, and they got a swollen limb, you find that they have DVT, and it just feels like, come on, you want to put a filter in, right? If that DVT travels, this person is not going to be able to tolerate it. So we were putting in a lot of IVC filters in patients that fit these criteria, having the acute PE in the ICU, not in shock, but feeling like they're towing the line and they have that DVT. So this was part of our practice to put in IVC filters. Should we do it? No. So they did not find any difference in recurrent recurrent PE. There was no difference in mortality. There really was no benefit at all. So this is a low-yield therapy, a low-yield intervention, and it really has changed how we manage our acute pulmonary embolism patients. All right, chlorhexidine bathing and healthcare-associated infections randomized trial. How many of you work in a setting where this chlorhexidine bathing, this soaking something in Purell happens on admission? Okay, so Scott Weinberg in the back, does that, Brian? Okay. We were doing something like this. We weren't being dumped into a trough or a clawfoot tub full of chlorhexidine, but it's pretty standard as patients come in that we have these chlorhexidine wipes and they're getting all wiped down. And it feels like, yeah, that should be the right thing to do maybe. So the intervention here was a large trial, it was 10,000 patients, randomized by on the ICU level, the way you would want to do an intervention like this. And they looked at a composite outcome of central line associated bloodstream infection, catheter associated urinary tract infection, ventilator associated pneumonia, and the occurrence of C. diff. So here is what looks like a forest plot, but these are all of the outcomes that they looked at. And you can see that there was no benefit to this intervention. That the clawfoot tub full of chlorhexidine should be wheeled out of the ICU. So this is another low-yield, high-expense intervention. So don't do it. A couple of very interesting papers came out throughout the summer. High-flow oxygen through nasal cannula and acute hypoxemic respiratory failure. I'm just presenting this first one from the New England, but there were other papers that came out of the same analysis, and there are other groups that are looking at it less so in the medical population than the surgical. But here, this paper focused on 300 patients randomized to acute hypoxemic respiratory failure, not hypercapnic, but hypoxemic respiratory failure. And the interventions, there were 3 arms. They had a high-flow oxygen arm, standard oxygen arm, and standard non-invasive ventilation arm. And their outcomes were intubation at 28 days and all-cause mortality at just around 3 months. So here's what the interventions look like. On average, patients that were in the standard arm got 13 liters a minute. On average, the high-flow arm was close to 50 liters a minute, and then BiPAP had pretty standardized settings. Again, a show of hands, who's using high-flow oxygen in their hospitals? Okay. Yeah, really interesting. So that's the most hands that have gone up so far. What did they find? So here's the primary outcome, intubation. You can see in the bottom in red, that's the high-flow oxygen group, and this is on the y-axis with the cumulative incidence of intubation. So you can see a lower rate of intubation in this group. And then here's their mortality signal as well. That mortality was, or actually it's a survival, that survival was lower at 90 days in the non-invasive arm. So very interesting. And this is the gem of the group. So this is the one that of all the papers, if any of them you leave today, this will be your new typewriter keyboard. Very cool paper. This came out in Lancet just about a month ago. And so this was the postural modification of the standard Valsalva maneuver for emergency treatment of supraventricular tachycardia. This is the reverse route. So they took 400 patients that had SVT, and they performed a modification to the standard Valsalva maneuver. So the Valsalva maneuver is where, I was taught to teach to tell the patient to slowly blow a balloon up to over a period of time, or to bear down. In different hospitals I've worked at, and I got night scares when I'm told to bear down. In Pittsburgh, people think it's like a hunting term. But they had the intervention of modifying the Valsalva by having the patient perform the Valsalva and then immediately get laying back and having their legs brought up in the air. I've got a video to show this too. This is very cool. So the outcome was return to sinus rhythm within 60 seconds. So here's the primary outcome. So 43% of patients with a modified Valsalva had return sinus rhythm within 60 seconds compared to the standard Valsalva, which actually 17% feels high, but I think that I rarely even try it anymore. So this is really interesting. They were able to increase stable tone, increase the venous return, and successfully have the person revert back to sinus. The number needed to treat for this no-cost, not dangerous intervention, 3 patients, so that's a pretty good profile. And here's a video of them doing it. It's just going to loop through. The sound is not important. I can make the sound. We'll watch it one more time. So what's that thing that he was breathing into? So they've modified a sphygmomanometer so that you can maintain 40 millimeters of mercury for 15 seconds. Ugh, that's awful. Who carries around one of those in your pocket? So that was the only limitation to the study, is that they have a device that requires a little bit of creativity to create. But what's cool is that another group was also interested in this, and they determined that you probably already got one of these in your crash cart. And if you take a 10 milliliter syringe that has a rubber plunger, put your mouth on the end of it, and blow hard enough to move the plunger, that's about 40 millimeters of mercury pressure. So you've already got one of these. You put this in the patient's mouth, have them exhale to move the plunger for 15 seconds, flip their legs up, and there's a much better chance of them going back into sinus. So I think that could maybe be the most practice-changing article of the bunch. This idea of innovation and how innovations move throughout society, this is a fascinating field of research, and I encourage you, if this is something that's tickling you, to check out the New England, because about a month ago, David Ash had a really interesting paper where he was looking at innovations not just as a fad, but as a real discipline, and also looking at how it can be a lower cost way of determining future research directions. So very, very cool paper. Definitely encourage you to go get it August 13th of this summer. And for a deeper dive into it, Everett Rogers has now in its 5th edition this book, The Future of Innovations, which goes into a lot more detail about the typewriter example that I gave, but also just looks at how as a society we collectively move the needle and how sometimes there are missed opportunities for innovations that don't get picked up. So if anything today, when you think about typewriters, and typewriters being a great example of successful innovation with the Electrolux and the change in how the hammers would strike, but also the keyboard that never really picked up, never really caught on. And so with the slightly shaky internet yesterday, I wondered, what are you talking about this keyboard? Is this keyboard even available? And so in fact it is. So you can get it through Amazon Prime. It's expensive because it doesn't have widespread adoption. It's not being manufactured by many companies, so it costs $100. There's only 5 left, so you'll have to move now if you really want this. But it is a faster keyboard. An example of this, a problem with picking up innovations though, is if you pick up this keyboard, obviously no one else is going to want to use your computer, so that might be a good or a bad thing. And I'll turn it over to any questions.